Good morning, everybody. I'm thrilled to be kicking off the inaugural meeting of the Advisory Council for Parkinson's Research, Care, and Services today. I'm Amy Bonnie Adams. I am serving as the Acting Director of the National Institute of Neurological Disorders and Stroke at NIH. And as such, I am serving as the chair for this meeting today. For the benefit of all of the public who is joining us here virtually online, I'm going to take just a moment to recap how we got here today. On July 2nd, 2024, the Dr. Emmanuel Bilirakis and Honorable Jennifer Wexton National Plan to End Parkinson's Act was signed into law. This law calls for an integrated national plan to prevent, diagnose, treat, and cure Parkinson's, ameliorate symptoms, and slow or stop disease progression. This plan will include not only Parkinson's disease, but will also encompass all other neurodegenerative Parkinsonisms, such as multiple system atrophy, corticobasal degeneration, progressive supranuclear palsy, and Parkinson's-related dementia. The National Plan to End Parkinson's will be developed with input from you, the Advisory Council on Parkinson's Research, Care, and Services, which includes people living with Parkinson's, caregivers, healthcare providers, researchers, advocacy organizations, and representatives from federal agencies. Since the law was signed into action, folks at HHS, NIH, and the National Institute of Neurological Disorders and Stroke have been working tirelessly to get us to today's meeting of the Advisory Council. And I want to thank each and every one of you members here today who have also contributed in critical ways. Despite this broad commitment to advancing the goals of this legislation that really we felt across the board, I'm going to acknowledge upfront that we have not met the deadlines laid out in the legislation that establishes this council, which called for the inaugural plan to be submitted to Congress in January of 2026. We are very anxious to move forward and fulfill that call to action in the legislation. And so we will discuss today a work plan that will get us to a high quality, useful, catalytic national plan as quickly and effectively as possible. But first, I would like to thank the people that got us to this point, especially people with lived experience of Parkinson's disease, progressive supranuclear palsy, multiple system atrophy, corticobasal degeneration, Parkinson's disease, dementia, and all other neurodegenerative Parkinsonisms. We know that these are progressive neurodegenerative diseases, and every month counts for patients, caregivers, and families. That has been at the forefront of our minds throughout this process, and it will be our guiding star throughout the work of this council. I want to thank our federal partners who have spent the past 9 months preparing for this meeting and who have jumped into the work on top of their regular duties and during a period of change. Thank you to our council members for volunteering their time for this effort. We were overwhelmed by the enthusiasm that we saw during the nomination process. Thank you all. Thank you to the public for your continued engagement. We read every public comment that was sent in, and we will continue to look for ways to get broad public engagement throughout the creation and implementation of the national plan, including the request for information, which just went live. And finally, I would like to thank the congressional members who have championed this legislation, and I would particularly like to thank former Representative Wexton and Representative Bilirakis, who have been directly, personally impacted by neurodegenerative Parkinsonism. Representative Wexton through her own journey with PSP, and Representative Bilirakis through his late brother, Emmanuel's battle with Parkinson's disease. Their choice to make their experience public is not an easy one, but it is one that has mattered immensely. So now I'm going to pause for a moment, and I am pleased to have video remarks from Congressman Bilirakis and fellow National Plan to End Parkinson's Act co-sponsor, Congressman Paul Tonka.
It is truly an honor to welcome each and every one of you to the inaugural meeting of the newly formed Parkinson's Council. This is a day that is deeply meaningful to me, both personally and professionally. The creation of this council represents years of advocacy and bipartisan collaboration. That's what it takes. But more importantly, it represents hope. The legislation establishes this council. The council bears the names of two extraordinary individuals. My late brother, Dr. Emmanuel Bilirakis, devoted his career to improving the lives of patients and advancing medical care. His compassion, intellect, and commitment to finding better treatments continue to inspire me every single day. It is also named in honor of my former colleague, a dear friend, Jennifer Wexton. She did an outstanding job, ladies and gentlemen, particularly on these issues when she was in the United States Congress. Her courage and determination in the face of an aggressive form of Parkinson's disease have inspired countless Americans. She continues to do so. Together, their legacies remind me, and it reminds all of us, why this work matters so profoundly. I want to sincerely thank each of you for agreeing to serve on this particular council, a very important council. Your expertise, your dedication, and your willingness to work across disciplines are exactly what is needed to confront one of the most challenging neurological diseases of our time. Parkinson's affects not only those living with the disease, but also their families, the caregivers, and of course the entire community. They're counting on us to accelerate research, improve care, expand access to innovative treatments, and ultimately find a cure. And we will find a cure if we work together. Today's meeting marks the beginning of an important journey. I know that meaningful progress requires collaboration, scientific excellence, and a shared sense of purpose. I'm confident we have assembled the right team to make a lasting difference. Thank you for your service, your commitment, and your willingness to answer this call. I know it's a sacrifice on your part, but we're gonna make it worthwhile, because we will find a cure. We won't stop until we find a cure. So I look forward to working alongside you as we strive to improve lives and bring hope to millions of Americans, improve their quality of life. Together we can honor Dr. Emmanuel Bilirakis, my brother, who just did so many great things in the community, and Jennifer Wexton, and every individual affected by Parkinson's disease, by turning today's conversation into tomorrow's breakthroughs. Thank you again, and I wish you a productive, successful meeting. I want to actually do a shout out to Dr. Oken, who has worked with me on this particular issue for years. But all of you mean the world to me. Let's get this done together. God bless each and every one of you. It is truly an honor.
Good morning. I'm Congressman Paul Tonko of New York's 20th Congressional District. I am indeed honored to join you today at the inaugural meeting of the Advisory Council on Parkinson's Research, Care, and Services. This is a monumental step forward to creating a federal plan to address Parkinson's and bring hope to those living with this disease. I am proud to have championed the Dr. Emmanuel Bilirakis and Honorable Jennifer Wexton National Plan to End Parkinson's Act. I want to thank my colleagues, Congressman Gus Bilirakis and Senators Shelley Moore Capito and Chris Murphy, for their steadfast partnership on this historic feat. In the United States, nearly 1 million people are living with Parkinson's disease, with more than 6 million people affected worldwide. It is the second most common neurological disease, with nearly 90,000 new cases diagnosed each and every year. Currently, there are no treatments to cure, prevent, or significantly slow down its progression. However, there is hope on the horizon. The passage of the National Plan to End Parkinson's Act charts a path forward by uniting the federal government in a mission to cure and prevent Parkinson's, alleviate financial and health burdens on American families, and reduce government spending over time. As mandated by law, HHS delegated authority to the National Institutes of Health to establish the Advisory Council on Parkinson's Research, Care, and Services. And on April 10th of 2026, HHS announced the newly established Advisory Council, which includes representatives from federal agencies like the Centers for Disease Control and Prevention and the Environmental Protection Agency. The Advisory Council also includes non-federal experts, including Parkinson's patient advocates, caregivers, and clinicians. The Advisory Council is tasked with providing guidance on Parkinson's-related issues, including recommendations for priority actions to be included in the national plan. I am indeed grateful to HHS and NIH for its partnership on commitment to bringing together federal and public leaders to ensure that every voice is represented in shaping the national plan to end Parkinson's. Today marks an important first step, but our work is just beginning. Let us continue working together to advance research, improve care, and strengthen support for those living with Parkinson's and their families. Thank you for your vital work. Let's go out and conquer. Good morning. I'm Congressman Paul Tonko of New York's 20th Congressional District. I am indeed honored to join you today at the inaugural. Good morning.
Thank you so much. I really hats off to the AV folks because it's not trivial to incorporate pre-recorded messages, but I'm really glad that we were able to hear from those co-sponsors of the bill and their inspiring comments on the importance of the work that we are embarking on today. So finally, I would just like to personally thank the people at NIH and NINDS who made this happen. When the legislation was first passed, staff from our extraordinary NINDS Office of Science Policy and Planning helped set us up for success here today, especially Drs. Paul Scott and Christine Torberg. Over the months that followed, NIH staff from the Office of Legislative and Policy Analysis, spearheaded by Dr. Amanda Field and Jennifer Bayerlein, and the Office of Federal Advisory Committee Policy, led by Zita Charles and Patty Brandt-Hansberger, worked to manage the delegations of authority, develop the Legislative Implementation Action Plan, and establish this new Federal Advisory Committee, a heavy lift at any time, but certainly more complicated by the transition of administrations. We are also grateful for the ongoing advice and guidance provided by Helen Lamont and Maria Okafor from the Office of the Assistant Secretary of Planning and Evaluation at HHS, who were endlessly generous with their time and their reflections on the experiences of establishing the National Alzheimer's Project Act Council. Finally, we are poised to advance this new national plan for Parkinson's disease thanks to the team of scientific experts across NIH, including from the National Institute of Aging, the National Institute of Environmental Health Science, the National Institute of Diabetes and Digestive and Kidney Diseases, and NINDS. Here at NINDS, those experts include Dr. Clinton Wright, the director of our Division of Clinical Research, as well as Drs. Christine Swanson-Fisher, Beth Ann Sieber, Shireen Sarath, Arvind Shukla, and many, many others. We have a small but mighty team in the NINDS Office of the Director, and I am endlessly grateful for the heroic contributions of Nora Hathan and Drs. Katie Lehman, Sarah Dodson, and Jordan Gladman for getting us here today. And last but not least, I am eternally grateful for the leadership of our former NINDS Director, Dr. Walter Koroshetz, whose dedication to advancing our understanding of Parkinson's disease and helping people with lived experience of that disease inspire our efforts today. So now I'm going to very briefly summarize the agenda before handing it off to Dr. Jordan Gladman, our designated federal official. Dr. Gladman will give some background about the council, and then council members will have the opportunity to briefly introduce themselves. Dr. Gladman will discuss the federal statute underlying the council and will walk through the council's charge and support that will be provided. We will then have brief presentations from our first set of federal agencies, those predominantly focused on research. And after those presentations, public council members will have the opportunity to ask questions to expand our understanding and clarify things from their federal colleagues. After lunch, we'll have our second set of presentations from agencies more focused on care and services, although obviously research, care, and services are intermingled, so these separations are pretty fluid. Then I will lead a discussion of the council's goals and principles, and we'll discuss insights from the National Alzheimer's Project Act to see if those would be helpful in guiding our work here today and in the future. Dr. Sarah Dodson, Senior Advisor within the NINDS Office of the Director, will lead a discussion of the council work plan. Then following a quick break, we will hear from several members of the public who have submitted formal public comment to the council. Remarkably, more than 160 individuals submitted written comments, which just signals how eager our community is to see the work of this council move forward. We will close with next steps and action items for our council members. So now I am happy to turn the meeting over to the council's designated federal official, Dr. Jordan Gladman. Jordan?
Dr. Adams, and I also am excited to help call this inaugural meeting of the Advisory Council on Parkinson's Research, Care, and Services to order. My name is Jordan Gladman, and I am the designated federal official. I also work at the National Institute of Neurological Disorders and Stroke at the National Institutes of Health. In the role of the designated federal official, I will help facilitate the work of this council and oversee its actions. That includes supporting council operations and helping you achieve your goals. Some of that also includes things like managing conflicts of interests and ensuring that we're compliant with the Federal Advisory Committee Act. I'll briefly talk about the National Plan to End Parkinson's Act, though you've heard a little bit about it from the actual sponsors, and then we'll allow the council members to introduce themselves. The full bios for each of our council members is on the NIH National Plan to End Parkinson's website, and will also be included in the materials posted for the public. Of note, we have a logistic support from Mathematica. They'll be helping advance our slides. You just need to indicate next when you want to move forward. And they're also helping us with any other AV and tech support. So council members, if you have any questions, please just message them in the chat. The National Plan to End Parkinson's Act was signed into law in July 2nd, 2024, and it calls for an integrated national plan to prevent, diagnose, treat, and cure Parkinson's. It establishes this council, which consists of 10 public members and 13 federal members. Of note, it encompasses both Parkinson's disease and the neurodegenerative Parkinsonisms, which include multiple system atrophy, corticobasal degeneration, progressive supranuclear palsy, and Lewy body dementia. Next slide. There were statutory requirements for the public members, including 2 patient advocates, including at least 1 individual who is living with young onset Parkinson's, a family caregiver, a healthcare provider, 2 biomedical researchers with Parkinson's related experience, a movement disorder specialist who treats people with Parkinson's, a dementia specialist who treats people with Parkinson's, and 2 representatives from the Parkinson's-related nonprofit organizations. The nomination period was open for 2 months, and we received 246 nominations, including 134 unique nominations from across 30 different states. 32 organizations submitted nominations, including professional societies, national nonprofits, local nonprofits, universities, and biotech companies. 2 subject matter experts evaluated every nominee, and a slate of nominees was submitted to Secretary Kennedy, who made the final appointment. Next slide. I'm now going to call on each of our council members to briefly introduce themselves, starting with the public members and then moving to the federal members. Bradley Beauvais.
Thank you, Jordan. Hi, everyone. I'm Brad Beauvais. I'm a neurologist trained in cognitive behavioral neurology and sleep medicine. I've worked here at Mayo Clinic for almost 30 years. My interests are primarily in REM sleep behavior disorder, which is typically a prodromal condition that evolves into PD or dementia with Lewy bodies or MSA. Also a strong interest in Lewy body dementias, PSP, and CBD. I'm very honored to be a member of this panel.
Thank you. Alice Chen Plotkin.
Hi, I'm Alice Chen Plotkin. I'm the Parker Family Professor of Neurology at the University of Pennsylvania. This will be my 20th year being a Parkinson's disease movement disorders doctor, and I also run a research lab that focuses on understanding the mechanisms behind neurodegeneration in hopes that we can stop these diseases. I'm really excited to be here.
Jessie Keaveney.
Hi, everyone. My name is Jessie Keaveney. I was one of the primary caregivers for both my dad and my uncle who lived with Parkinsonism and dementia. After I learned that I carry one of the genetic variants associated with Parkinson's, I've spent the last 13 years participating in more than 40 research studies, mainly focused on biomarkers, prevention, and precision medicine. I'm honored to represent care partners, families, individuals at increased risk of Parkinson's and related disorders, and of course, research participants. Thank you very much for allowing me the opportunity to serve.
Thank you. Israel Rebeldo.
I'm Israel Robledo, and I'm in Midland, Texas. I was diagnosed with Parkinson's 19 years ago. Young onset, just at the beginning of my teaching career. Thankfully, I've been able to continue working, but I tell people much of what I do is based on the quality of care that's provided from research. And I look so forward to making Parkinson's one for the history books. Thank you.
David Standard.
Hi, I'm David Standard. I'm a movement disorders neurologist and scientist. I'm currently chair of the Department of Neurology at the University of Alabama at Birmingham. I've been involved working with people affected by Parkinson's and their families for over 30 years now. I do treat and diagnose a number of patients at the clinic over the years, but we've led research programs trying to understand the cause of Parkinson's, how you could modify progression, trying to understand some of the adverse effects of the treatments that we use, like wearing off and dyskinesia, and have been engaged in clinical trials as well. So I'm really excited to be here. I hope this is a moment where we'll change the future for people affected by Parkinson's.
Michael Oken.
Hi, my name is Michael Oken. I'm a neurologist at the University of Florida. It's an honor to be here today. I am overseas, so I just want to let people know in case you're having trouble hearing me. I've been in movement disorders and Parkinson's disease for 24 years at the University of Florida, where I've chaired the Department of Neurology in the past and now run an institute called the Fixell Institute for Neurological Diseases. And we have a real emphasis, and I personally have a lot of emphasis on making sure that we do the things that are necessary to move this disease forward, especially for our communities. And so thank you for having me, and it's an honor to be here.
Kathy Ann Thomas.
Hi, thank you. I'm Kathy Thomas, and I'm a clinical nurse specialist and work at Boston University Medical Campus in the Department of Neurology. And I've had the privilege to work with individuals and families impacted by Parkinson's disease and the other neurodegenerative Parkinsonisms for 45 years. So it's certainly been rewarding. Very happy to be part of this committee and look forward to a lot of good work.
Sure.
Hi, everyone. I'm Jessica Shore. I spent the first 10 years of my career as a clinical social worker at a Parkinson's Foundation Center of Excellence. I currently serve as the Director of Clinical Affairs and Advocacy at an organization called Cure PSP. We're the leading nonprofit organization dedicated to the awareness, care, and cure for progressive supranuclear palsy, corticobasal degeneration, and multiple system atrophy. And here I manage our international network of medical centers working to improve best practices for the diagnosis and symptom management for these three atypical Parkinsonian conditions, as well as oversee all of our community engagement, education, and direct support programs. I really look forward to learning from and collaborating with my fellow council members who share my passion for addressing the unmet needs and empowering the Parkinsonism community. And as a side note, I just have to say that before this, I texted former Representative Jennifer Wexton just to thank her for paving the path for myself and all of us to get here today. So holding her close to my heart during this first meeting. Thank you.
Sarah Whittingham.
Hi, I'm Dr. Sarah Whittingham. I'm a physician, Air Force veteran, author, and mom. I was diagnosed with PD in 2020 at the age of 46. Ironically, it turned out my medical background felt like a disadvantage. To truly thrive, I had to unlearn much of what I thought I knew about PD, and much of what helped me the most go on to compete in marathons and triathlons came from the Parkinson's community and some of the incredible nonprofits that serve us. That experience led me to write a book called Oh Crap, It's Parkinson's, and it's my hope that this helps everyone touched by Parkinson's, from those newly diagnosed clinicians, researchers, and families, see not only the challenges of the Parkinson's community, but also what's still possible with hope, community, gratitude, and outrageous dreams. My advocacy's also been focused on ensuring our veterans exposed to toxins have access to the care we deserve and helping us better understand and reduce the environmental and occupational exposures that may contribute to Parkinson's in future generations. I'm honored to serve on this council and look forward to working with all of you.
And Deborah Brooks.
Hi, everybody. My name is Debbie Brooks. I'm CEO and co-founder of the Michael J. Fox Foundation for Parkinson's Research, and I'm honored to serve on this council representing the nonprofit community. For more than 25 years, I've worked alongside patients, families, researchers, clinicians, policymakers, regulatory individuals, and advocates to help accelerate progress against Parkinson's disease and atypical Parkinsonisms. That experience has really reinforced the importance of bringing diverse perspectives together around a shared goal and maintaining a relentless focus on outcomes. I'm grateful for the opportunity to contribute the patient and nonprofit funder experience to this work, and I look forward to partnering with each of you to help advance meaningful progress for those who are living and impacted by Parkinson's and Parkinsonisms.
Thank you so much. And thank you to all of our federal members. It's very exciting to have you all here today. And note that many of you rearranged your schedules to make this meeting fit in, and we very much appreciate it. Next slide. We also have 13 federal council members. The federal council members are also able to send an alternative representative if they're unable to make it. So I think there will be a few cases of that today. Dr. Amy Bonnie Adams, I know you've already introduced yourself, but do you have anything additional to add?
No, I just want to echo your appreciation, Jordan, for everyone for being here today and helping us move the work of this important council forward.
Maria Bellantonio from the Indian Health Services.
Good morning. Thank you, Jordan. Hello, everyone. I'm Maria Bellantoni. I am an internist and geriatrician. I serve as the chief clinical consultant for geriatrics and palliative care for the Indian Health Service. In this capacity, I help guide agency programming related to care of older adults. And I'm also the physician consultant for the IHS Alzheimer's program, which leads the agency activities related to care of individuals living with dementias, including Parkinson's and other related disorders. Thanks so much for the opportunity to be here and to serve alongside all of you.
Leslie Bartran from the Defense Health Agency.
Hey, good morning, everyone. I am Dr. Leslie Beltran. I am the program manager for the Parkinson's Research Program. I'm a behavioral neuroscientist by training and worked as a basic scientist in academic labs, developing therapeutics for Alzheimer's and Parkinson's before transitioning to civil service. As program manager for the Parkinson's Research Program, I provide strategic direction to develop the program's investment strategy and funding opportunities, oversee peer and programmatic review and research proposals, and evaluate program accomplishments, including outcomes of funded awards for our stakeholders. Happy to be here. Thanks.
Lisa Belchio from the Food and Drug Administration, though I think perhaps we have an alternative on today.
No, that's me.
Oh, perfect.
Hi.
You're here. Excellent.
Hi, I'm Teresa Baracchio. I'm the director of the Office of Neuroscience. I'm also a neurologist. My office is in the Center for Drug Evaluation and Research at the FDA. Our group oversees the regulation and oversight of drug development programs for Parkinson's disease and related disorders. However, we also do work closely with the other centers at the agency that regulates medical products such as the gene therapy products and devices. And happy to be here today. Thank you.
Thank you. Mary Lazar from the Administration for Community Living. I think perhaps we have an alternative for them today also.
Good morning, everyone. I am Rick Nichols, serving as alternate for Mary Lazar this morning. Mary serves as ACL's senior official that is acting as Assistant Secretary for Aging and ACL Administrator. I serve as Chief of Staff at ACL. Just wonderful to be with everyone today.
Flo Teal from the National Science Foundation, or the alternative.
So I think I'm the second alternative today. Hi, I'm Stephen Zender. I'm from the U.S. National Science Foundation. To give a little bit of background on Flo, she is currently a program director in our Directorate of Technology, Innovation, and Partnerships, work focused on broad translational portfolios for biotechnology initiatives. I'm currently a program director in our Engineering, Biological, and Biomedical Systems. It's a new program name, and I also am really honored to be here. Thank you.
Don Judah from the Department of Veteran Affairs, or a representative.
Jordan, I don't believe that Dr. Duda's representative will be on until later.
So later. Next, Stephanie Herodopoulos from the Office of the Assistant Secretary of Health and the Office of the Surgeon General.
Good morning, everyone. Just honored to be here. I'm a family medicine physician from Florida with a public health background, and it's really just a true wonderful experience to be part of this nascent federal advisory committee. Thank you. I'm currently the director of the National Health Communications for the Office of the Surgeon General, as well as the Principal Deputy Assistant Secretary of Health in OASH. And, you know, we kind of have a different role here at the Surgeon General's office. We communicate as a nation's doctor to the public, awareness and prevention. So we don't have some programmatic teeth like some of the agencies are on board here, but we do have the responsibility of important contribution, and that's approaching it through our superpowers. And that's to say that we can convene partners, coordinating around shared public health priorities and communicating clear about what we know and what's still emerging and why it matters to patients, families, caregivers, and communities. So we come from what we can do to prevent it. We know that most Parkinson's disease cases are not genetic and could be due to multifactorial environmental factors. So that's the angle that we come from the Surgeon General's office. Thank you for having me.
Thank you. Captain Gayatri Kumar from the Office of Minority Health.
Good morning, everyone. My name is Gayatri Kumar, and I'm the Chief Medical Officer at HHS Office of Minority Health and a captain in the U.S. Public Health Service. In my role as CMO, I provide clinical expertise and insight for OMH programs and activities to help address health disparities and improve health outcomes for racial and ethnic minorities in the United States. I'm also an internist by training. When it comes to Parkinson's disease, it is more of a personal connection for me. I know of close to 10 people in my life, including a dear relative of mine, all of South Asian descent, who have been diagnosed with this disease. Therefore, to see this council succeed in its mission is of great value and importance to me, and I'm grateful to be part of a brilliant team to bring our minds together to establish a powerful plan and make progress and outcomes. Thank you.
Nancy Beck from the Environmental Protection Agency.
Morning. Thank you, Jordan. I'm very appreciative of the opportunity to be here today. I'm a PhD toxicologist serving as the Principal Deputy Assistant Administrator in EPA's Office of Chemical Safety and Pollution Prevention. So my office has a responsibility for approving all new chemicals and pesticides before they can go to market and be used by American consumers and businesses. In addition, we also conduct human and environmental reviews of existing chemicals and pesticides that are already in the market. I look forward to providing a bit more detail about this later this morning. Thank you again for the opportunity.
Thank you. Next slide. Roger Klein from the Agency for Healthcare Research or Quality, or a representative. I'm not sure one was able to attend today, so hopefully we'll see them later in the afternoon or at our next meeting. Sherry Ling from the Centers of Medicaid and Medicare Services.
Hi, good morning. Sherry Lane, Deputy Chief Medical Officer for the Centers for Medicare and Medicaid Services. I'll go into a little detail later today about what CMS does, but you probably know our work as the largest payer for global healthcare delivery. I am a geriatrician and also a volunteer dementia care provider serving veterans in Baltimore. Really delighted and honored to be here with you.
Thank you. And then Captain Francisca Abanye from the Centers for Disease Control and Prevention.
Thank you so much. So as mentioned, I'm Captain Francisca Abanye. I'm a medical officer here at CDC, serving as the acting principal deputy director of our Office of Science. I don't have a professional connection to Parkinson's, but I do have a personal connection. I actually have a family member with Parkinson's who recently passed away. But I will be presenting the work of the agency, the great work that our SMEs are doing today. So thank you for the opportunity to be a part of this council.
Thank you. And thank you to all of our federal members and all of our public members. I've been working with this group for about a month and a half, and I have to say it is an excellent group. I'm looking forward to the work that we're going to accomplish. Next slide. I'm going to give a brief overview of our charge and charter, but as Dr. Adam mentioned, in the afternoon section, we're going to go a deeper dive into the goals and outcomes in the work plan that we're proposing. Next slide. A brief overview of the Federal Advisory Committee that is the Advisory Council on Parkinson's Research, Care, and Services. It is governed by the Federal Advisory Committee Act, FACA. It's designed to provide advice informed by community input in the latest research to the HHS Secretary and federal agencies. This advice is then used to govern federal efforts, for instance, the development of a national plan to end Parkinson's. A federal advisory committee does not fund research or allocate federal research dollars, control funding or implementation of federal programs, create or set federal policy, create policy for state or non-governmental organizations, or create medical guidelines. But all of the work this committee does will directly help inform the federal government in its work in Parkinson's and ending Parkinsonisms. Next slide. One of the key tenets of the Federal Advisory Committee Act is this focus on public interest, public engagement. As such, it is the federal government and not private interests that help control and establish the agenda. These meetings give voice to multiple viewpoints, including dissenting viewpoints. It prevents and manages potential conflicts of interests and ensures that membership is fair and balanced. We make all of the materials available online after the meeting. We allow public comment, and as Dr. Adams said, we had over 160 written public comments. We'll be able to hear from a small subset of that today, and we intend to carry that forward into all of our meetings in the future. And each of these meetings is listed in the Federal Register as public notice. Next slide. So under the National Plan to End Parkinson's Act, there are several functions that this specific advisory council is set up to help us do. I'm going to briefly outline them, and we'll talk a little bit more about how we're going to accomplish them in the afternoon. So first, for the first 2 years, hold 4 or quarterly advisory councils, and that includes this year. Even though we're getting a little bit late start, we're going to have 4 council meetings this year. After 2 years, we have a little bit more flexibility on the cadence of our meetings. We're going to coordinate federal programs on Parkinson's and related disorders, and this includes producing an annual inventory of federal programs. This council is in charge with convening an annual Parkinson's research meeting and annually submitting a report to the HHS Secretary and Congress with recommendations and priority actions. We're also asking that you help us determine the investment necessary to prevent, diagnose, treat, cure Parkinson's and related disorders. Our charter is filed online and is also posted on our website. Next slide. Even though this is the first meeting publicly of the council, there's been a lot of work behind the scenes leading up to this meeting. I just want to highlight a little of it to help everyone understand where we currently are. As mentioned at the beginning, the National Institute of Neurological Disorders and Stroke at the National Institute of Health is responsible for implementing the National Plan to End Parkinson's Act that was delegated down from the Department of Health and Human Services. That includes convening the annual research meetings. We're currently working with the National Academies of Science, Engineering, and Medicine to help us provide the logistical support for these meetings through fiscal year 2028. This will not only include the annual research meeting, which we are required to do, but we felt it important also to hold an annual meeting on care and services. This will help the council focus on providing substantive input and not have to worry about hosting one or two labor-intensive meetings each year. Additionally, producing that federal inventory has already started. Since September of 2025, different federal partners have been meeting monthly to discuss what is being done within their agency on Parkinson's. And in fact, the presentations you're going to hear this morning and this afternoon begin to touch on some of that. NIH has already begun work in developing a new category to track funding that will include progressive supranuclear palsy, multiple system atrophy, and corticobasal degeneration, along with kind of a roll-up category to track all of the Parkinsonisms total. We're also developing a system that will help us track and report on all of the programs across the federal government. We've also developed a request for information. Next slide. This was just recently published, and it seeks broad public input to support the development of the national plan and to inform the work of this council. It is open to anyone, any member of the public. We're especially interested in hearing from people with lived experience with Parkinson's disease and caregiving, researchers, healthcare professionals, patient advocates, and advocacy organizations. You can scan the QR code that's here. You can search for that notice online. These slides will be made available, and you can click on the link to the federal to the request for information. It has both a way to submit online through a web form in our mailbox if you have additional questions. Please keep in mind that the response date is August 22nd. Then after the fact, the NDS will be working to analyze and share those results. Are there any questions from our council members before we hand it over to the next section focused on the other federal agencies? Hearing none, the next slide. I'm going to turn it over to Dr. Katie Lehman, who will be helping organize the first section of the overview of federal programs.
So, thank you, Jordan. Good morning, everyone. We are thrilled to have many federal agencies here today with us to tell us a little bit about their agency mission and how that mission relates to Parkinson's disease and related disorders. This is the first of two sessions where federal agencies named in the National Plan to End Parkinson's Act will briefly discuss the goals of their agency and how those goals relate to the work of this council. Each agency will have 5 minutes to present. We'll call time around 4 minutes, so just there'll be a verbal reminder that you have about 1 minute left. At the end of all the presentations, we'll have time for the public members to ask questions. We know the public members have many questions, and some of them have started to brainstorm what those are before this council, so they can ask those questions now or any other questions that arise as these presentations move forward. We ask that the public members use the raise hand feature to ask their questions, and we'll try to make sure that everyone gets a chance to ask any questions or provide any thoughts during this time. So if you've already spoken, I may skip over you to give the chance for someone else to speak. If any questions aren't addressed today, there will be 3 more meetings this year, as Dr. Ladman mentioned, and there will be working group meetings to further dig into any thoughts that people have. We do want to say that federal agencies may not be able to answer every question today, but we'll record them and they will follow up with you as they are able. With that, I would like to turn it over to our first presenter, Captain Abanye from the CDC.
Thank you so much. You can advance to the next slide. So I'd like to start by briefly reading CDC's mission and priority statement as a framework for the rest of the presentation. CDC aims to protect the lives of all Americans, advancing health through science, technology, and innovation. CDC leads with integrity to prevent and protect from diseases, detect emerging threats, both domestically and internationally, and drive state-of-the-art solutions, empowering communities and strengthening public health systems for a safer, healthier nation. Next slide, please. Along these lines, CDC has undertaken work on Parkinson's disease as part of its National Neurological Conditions Surveillance System, or NNCSS. Congress authorized CDC to develop NNCSS in 2016 through the 21st Century Cures Act. CDC has received $5 million in annual appropriations since fiscal year 2019 to do this work. NNCSS is a public health surveillance system that provides population-level data to better understand the burden and distribution of neurological conditions within the United States. CDC analyzes and shares these data to help inform both research and action, including research to increase understanding of risk factors, promote earlier diagnosis and intervention, and improve patients' quality of life, as well as decision-making about priority programs to improve patient care. Next slide. NNCSS's work can be understood across 3 phases: previous progress, which is the work that has already been completed to date, current work, and next steps. Each phase aligns with the program's congressional mandate to build national surveillance capacity for neurological conditions. In its initial phase, CDC chose Parkinson's disease and multiple sclerosis as its first 2 conditions based on their high burden on patients and caregivers and differences in their diagnostic complexity and age of onset. These differences allowed CDC to test surveillance methods across these varied conditions, helping NNCSS prepare for future neurological surveillance complexities. CDC used these methods to produce NNCSS's first population-level estimates of Parkinson's disease prevalence in the United States, including differences by age, sex, region, and where available, race and ethnicity. These estimates were for 2019, which was the most recent data available at the time. This initial work established a scalable foundation for NNCSS's future surveillance. It also informed NNCSS's interim report submitted to Congress in 2020. CDC is now advancing ongoing surveillance of Parkinson's disease by applying and refining the established methods. Current activities include generating prevalence estimates for years after 2019 and expanding analysis to better understand disease burden. CDC is also sharing NNCSS methods and findings through peer-reviewed publications, congressional reports, and public-facing resources. A recent JAMA Network Open article describes CDC's national approach to PD surveillance, and the link can be found in the briefing document that was provided. A companion manuscript with prevalence estimates and other manuscripts are also in progress. Foundational NNCSS content is available on CDC's website, with additional resources in development to support interpretation and use of findings. A congressional report is also being finalized through the HHS review process. Together, these activities show NNCSS moving from initial implementation to ongoing surveillance focused on producing and disseminating consistent, repeatable estimates over time. Looking ahead, NNCSS's near-term priorities. Thank you. Near-term priorities are organized around 3 focus areas: expanding surveillance, increasing access to findings, and supporting use of the findings. CDC will maintain, refine, and expand surveillance by tracking prevalence, developing new estimates such as mortality, and examining differences in prevalence and mortality by factors like urban or rural residents. CDC will also evaluate data sources and methods to keep the system state-of-the-art and ready to add other neurological conditions while maintaining PD surveillance. CDC will continue peer-reviewed publications and congressional reports while expanding user-friendly resources to help audiences interpret and use NNCSS findings. We'll also develop resources to translate NNCSS findings into actionable insights and highlight evidence gaps to inform research funding. Of great importance, CDC prioritizes engagement with experts, national health organizations, and government partners to guide NNCSS development and implementation, address technical considerations, promote use of findings, and ensure activities meet stakeholder needs. Through these efforts, CDC aims to strengthen the practical application of NNCSS data by making findings accessible, advancing understanding of neurological conditions, and supporting decision-making across public health and healthcare research, policy, and practice. Thank you.
Thank you, Captain Abanye. That was very helpful. I'm sure there will be questions for you as we move into that portion, but for now we're going to move on to Dr. Beltran from the Defense Health Agency.
Good morning, everyone. Again, Leslie Beltran representing the Parkinson's Research Program. Next slide, please. This is our standard disclaimer, which states these views are not necessarily reflective of the Department of War and should not be construed as an official DoW position, policy, or decision. Next slide, please. The Parkinson's Research Program is one of 34 programs within the Congressionally Directed Medical Research Programs, or CDMRP, which is a funding organization within the Department of War's Defense Health Agency. The CDMRP mission is to transform, the vision is to transform healthcare through innovative and impactful research. To operationalize that vision, our mission is to responsibly manage collaborative research that discovers healthcare solutions for service members, their families, veterans, and the American public. CDMRP originated in 1992 via congressional appropriation to foster novel approaches to biomedical research in response to the express needs of its stakeholders, the American public, the military, and Congress. CDMRP research funds are specifically targeted by Congress and added to the Department of War budget on a yearly basis. CDMRP funds research according to each program area and funds high impact, high risk, and high gain projects that other agencies may not venture to fund. Each program's vision is adapted yearly and award mechanisms are changed as needed to meet the current needs of the research community. Notably, CDMRP funds the full pipeline of research development from basic science through clinical trials as appropriate to the state of the field of each program. And CDMRP awards are made to academic institutions and small businesses all over the world. CDMRP follows the two-tier review application process that was recommended by the National Academy of Medicine, and there are no standing peer review panels. CDMRP does not use a pay line, and applications that receive the highest scientific scores are not automatically funded. Applications are recommended for funding based on both their scientific merit and how well they address programmatic criteria. An important hallmark of CDMRP is the inclusion of consumers in the review process. These consumers include patients, survivors, family members, and/or caregivers of diseases and conditions that CDMRP research supports. Consumers serve as full voting members on nearly all CDMRP peer and programmatic review panels, and consumers are invited to participate on these review panels based on their involvement in advocacy organizations, the armed forces, and/or their personal experience with the disease or condition. It is our firm belief that consumers add a unique perspective and sense of urgency, ensuring that the human dimensions of the target disease, disorder, or injury are incorporated into program policy, investment strategy, and research focus. While individual programs are unique in their focus, all of the programs managed by the CDMRP share the common goal of advancing paradigm-shifting research to produce solutions that will lead to cures or improvements in patient care or breakthrough technologies and resources for clinical benefit. Next slide, please. The Parkinson's Research Program originated as the Neurotoxin Exposure Treatment Parkinson's Research Program in 1997. In 2002, Congress transitioned the name to the Parkinson's Research Program, and the program expanded to also include funding for all kinds of PD research, including and beyond neurotoxin exposure. To date, the Parkinson's Research Program has received a total of $64 million congressional special interest dollars, with FY26 appropriations totaling $16 million. The PRP vision is to improve the health and lives of people with or at risk for Parkinson's disease through innovative research that translates to clinically meaningful treatments. To operationalize that vision, PRP mission is to support high-impact research that intends to decrease risk, slow progression, or ease symptoms of Parkinson's disease that benefits service members and their families, veterans, and the general public. PRP has, thank you. PRP has a series of strategic or long-term goals, which are understanding the neurological underpinnings of the cognitive psychiatrics and other non-motor symptoms, understand the biological mechanisms or biomarkers of motor symptoms, delineate how gene-environment interactions impact the development and progression, determine mechanisms of dopamine refractory symptoms and treatment-associated adverse events, develop interventions that address unmet medical needs, and expand research capacity through an investment in early investigators. Next slide, please. The NETP and PRP invest in research to improve the understanding of Parkinson's disease and to accelerate interventions that address unmet medical needs. This table comes from our program summary sheet, which can be found on our website, and details how NETP and PRP's investment has resulted in high impact products. Briefly, NETP and PRP funded research has identified PD risk associated with residential exposure to commonly used environmental chemicals, developed a clinical risk assessment tool based on smell and neuroimaging, enabling earlier detection, identified irregular protein, if lost, results in a pathway toward eventual loss of neurons, and discovered the neuroprotective effects of carnosine, positioning this dipeptide as a potential therapeutic target. Thank you.
Thank you, Dr. Beltran. We will move on to the EPA, and Dr. Beck will be presenting.
Great, thank you. Next slide, please. So I just want to give you a high-level overview of our organization. EPA is organized to address specific releases to the environment, focusing on our regulatory programs, which are shown in the orange boxes. The Office of Air and Radiation evaluates releases to air. The Office of Water evaluates releases to water. The Office of Land and Emergency Management focuses on releases to land. My office, the Office of Chemical Safety and Pollution Prevention, which is shown on the right, as I mentioned, is responsible for the approvals and registrations of chemicals and pesticides. Because we operate under two very distinct statutes, we have two separate offices, the Office of Pesticides, which operates under FIFRA and FFDCA, and the Office of Pollution Prevention and Toxics, which is where we regulate chemicals. Next slide, please. I'm going to start with a quick overview of our chemicals program, which we regulate under the Toxic Substances Control Act, also known as TSCA. This was actually updated in 2016, and it provided EPA with additional authority to regulate chemicals, specifically new chemicals and also existing chemicals. In our new chemicals program, we have a requirement now to review and evaluate every chemical before it goes to market. Any chemical that is not on the TSCA inventory is considered a new chemical. And our evaluation looks at the human health and environmental impacts of all chemicals throughout their life cycle before a chemical can go to market. Currently, there are over 42,000 chemicals on the active inventory. Next slide. When a chemical is on the active inventory, it becomes an existing chemical. And we have an additional process to evaluate the 42,000 existing chemicals that are in the market. So we start with the chemical inventory. We prioritize the chemicals as our first step. Those that are deemed high priority move to a risk evaluation phase where we determine if there's unreasonable risk to human health and the environment. And if we find unreasonable risk, then we are required to go to risk management, which is essentially rulemaking to eliminate that risk. EPA has many regulatory tools in the toolbox to mitigate the risk. This includes chemical bans, workplace requirements, labeling, and use restrictions. Next slide, please. Because these existing chemicals have been on the market for many years, we rely on publicly available information to existing chemical reviews. So since 2016, we've done about 22 draft or final risk evaluations, and each of these had on average over 6,000 references per chemical. We're essentially mining the public literature to look at all the potential and possible health outcomes that have been evaluated for a chemical. I've listed these health outcomes in categories below. Of interest to this group, we do include evaluation of any information we find on neurological and behavioral effects, which may include information on Parkinson's disease. Next slide, please. So I want to switch over to our pesticides program, which is the other side of the house, where we regulate pesticides under FIFRA, which is the Federal Insecticide, Fungicide, and Rodenticide Act. This slide provides a bit of background on pesticide use in the United States, which, as you can see, is very broad. We have over 1,000 active ingredients that are used in over 18,000 pesticide products. Two important points here. Pesticides are used not only by food producers on farms, but also in households and in hospitals. They play very important public health roles. And also, I'll note that we have, while there are about 2 million farms, there are 1 million certified applicators. For those pesticides that have higher toxicity profiles, they can only be applied under someone who is a certified applicator. And I think that's an important point. Next slide, please. So to further help understand the breadth of our pesticide program, we generally break them down into 3 categories: conventional pesticides, which are often used in agricultural settings; antimicrobial pesticides, which are used in households, buildings, and hospitals; and then also biopesticides, which have agricultural and public health uses.
1 minute remaining.
Okay, next slide, please. I'm just going to quickly go through. The pesticide process is very similar to how a pharmaceutical is registered at FDA. The registrant for the pesticide is required to do millions of dollars of studies and information. Those studies and all those test results are presented to EPA, which then does the review of all the information that's provided. Most of the studies and data that we collect are required to be collected and done following guidelines, standardized guidelines and test protocols. Next slide. This slide just shows the type of information that the registrant is required to submit to EPA. Next slide. This slide shows all the human health data requirements that are required to come to EPA for evaluation. And then if you look at the next slide, that shows the requirements for all the environmental fate and effects information that is required to be submitted to EPA anytime a pesticide is reviewed. Finally, on the next slide, because there's great interest in paraquat, I want to give you all an update on our registration review process. So in 2021, we had an interim decision that identified the need for risk mitigations to address potential human health risks to occupational workers and bystanders. So that risk was implemented on product labels in 2022, and it put in place additional prohibitions for the use of paraquat. So it prohibited the use of mechanically pressurized handguns and backpack sprayers. It put limits on aerial spraying. It required enclosed cabs for ground equipment, and it increased the restriction entry interval for cotton. So these were important mitigations that went on the labels in 2022. Next slide. I also want to note that as part of our registration review, we are updating the systematic review for paraquat. We have under review 113 studies that were provided to us by the Parkinson's Disease Foundation, and those were submitted in 2023. We are continuously reviewing all the new scientific information as it becomes available as part of our registration review process. Regarding volatility, you may have heard that in 2024, a registrant submitted new vapor pressure data to EPA, and that indicated a higher vapor pressure than was previously used in our risk assessments. So based on this preliminary information and the uncertainty about this, we issued a data call-in, which is basically a requirement for registrants to do further testing and to send us further information about the volatility of paraquat. They've all agreed to provide us with that information. Once we have that information, we will then conduct another review and reassessment of its impact on the paraquat risk evaluation. So I think I'll stop there. Thank you very much for the opportunity.
Excellent. Thank you, Dr. Beck. We will move on to the FDA and Dr. Bracchio.
Next slide.
Yeah, let's
get to the FDA slide.
Yep.
Apologies. I provided a lot of background slides. I didn't expect to get through them all.
Okay, here we are. All right, so as I previously mentioned, I'm Teresa Bracchio. I'm Director of the Office of Neuroscience in our Center for Drugs at FDA. And just a high level, what our mission is we protect public health by ensuring the safety, efficacy, and security of human and veterinary drugs, biological products, and medical devices. So although that is our main mission, we do also have another important mission, which is to advance public health by helping to speed innovation that makes medical products more effective and safe and affordable, and to ensure that the public gets the accurate science-based information that they need to use those medical products. So next slide. At FDA, we have 3 main medical product centers that are involved in development of medical products for Parkinson's disease and related disorders. As I mentioned, I'm in the Center for Drug Evaluation and Research. We manage small molecule drugs, monoclonal antibodies, proteins, and we also have diagnostic imaging agents under our purview. In the Center for Biologics Evaluation and Research, they handle cell and gene therapy products. So for Parkinson's disease, they're more largely focused on genetic forms of Parkinson's disease, or if there are tissue or cell products that may have potential for therapeutic role in the treatment of Parkinson's disease, they would handle those, or vaccines. In the Center for Devices and Radiological Health, they handle both therapeutic devices and diagnostic devices. So they, in their purview, they have the deep brain stimulation devices and also in vitro diagnostic assays and general imaging that is not specifically imaging products that you might administer by IV. So next slide. We do have many FDA-approved medical products for Parkinson's disease. These are all generally considered to treat symptoms of the disease, but may have limited effects on modification of underlying disease pathology. There are many formulations of carbidopa, levodopa, including oral products, and then enteral products, and also an IV form of, or subcutaneous form of foscarbidopa, foslevodopa. We also have dopamine agonists, MAOB inhibitors, COMT inhibitors, amantadine, estradefylline, and also pimavanserin for symptoms of psychosis and Parkinson's disease. As I mentioned, our therapeutic devices and procedures are handled under our devices group and include deep brain stimulation, exablate, neuro, and tremor transducers. And there are also diagnostics agents that the dopamine transporter scan the DAT scan is handled in CEDAR it's an imaging product. However, recently cleared Neuropax device diagnostic aid, which is an MRI-based device, is out of our Center for Devices. And I think I got a pretty exhaustive list, although it's possible that I may have missed a few things. I think we do recognize, though, that despite what looks like a more extensive list than many of our other neurodegenerative diseases have, that we do still see the need for additional therapeutic products that will both help with diagnostic aids to help diagnose the disease as early as possible, but also that will help slow or halt disease progression. And so we keenly recognize the need for new therapeutic options. Next
meeting.
Okay, next slide, please. So what do we do? What is our role in medical product development? We are involved in the review of applications, both initial applications to conduct clinical trials in humans, but also for the approval of or clearance of medical products. So during that process, we provide advice. We work closely with developers of drug or device applications during their product to development to make sure that they are designing their programs in a way that they can provide the data that are needed to support either the initiation of a clinical trial or a future marketing application. We monitor ongoing clinical trials for safety, but we also do provide advice on how to use endpoints and study designs that will help to establish effectiveness of drugs or medical products. We do, under marketing applications, conduct a regulatory assessment for effectiveness and safety. And once a product is approved or cleared for the market, we do continue surveillance for safety in the post-marketing setting. We do have many active medical product development programs for Parkinson's disease and related disorders across our 3 medical product centers. And these are, as you saw on the prior slide, these we have a variety of different targets. Some are for symptoms primarily, some are targeting underlying disease pathophysiology, and some are targeted to causal genetic variants. Next slide. In addition to overseeing the development of products and making sure that the development programs are safe and are capable of providing evidence of effectiveness, we also, under that second objective that I had on the first slide, are about, one of our objectives is to push innovation and speed innovation in these spaces. So we do have very active engagement in pre-competitive and regulatory science efforts to address areas of opportunity to support current and future development of medical products. And there's listed here just a number of initiatives that we have been actively engaged in recently, but this is not an exhaustive list. Specifically, we've been very engaged in exploring the utility of digital health technologies to support clinical trial endpoints. And there was a specific effort under Watch PD using an Apple Watch that we've been engaged in. More recently, we've been working with the Michael J. Fox Foundation and the Critical Path Institute on optimizing the Movement Disorder Society Unified Parkinson's Disease Rating Scale to better reflect early current drug development needs to detect changes in the earliest stages of Parkinson's disease. We've also been engaged on the development of patient-reported outcomes for non-motor symptoms, and we are very involved in ongoing discussions around the development of biologic staging of Parkinson's disease and related disorders and synucleinopathies to divide early intervention strategies. Over the last 10 years, there have also been a number of patient-focused drug development meetings that we have attended and participated in. The first one being one of our very first patient-focused drug development meetings back in 2015. And more recently, we've participated in some for dementia with Lewy bodies and progressive supranuclear palsy. These meetings do provide the outcome of the meetings is a voice of the patient report, which FDA finds very helpful in guiding our advice and decision making as we review products for these conditions. And I think that is my last slide, so I'll turn it back to the floor. Thank you.
Excellent, thank you. Next up, we have NIH and Dr. Bonnie Adams will be presenting.
Thank you so much. Next slide, please. It's a privilege to be here today to tell you about the work of the National Institutes of Health. The mission of NIH is to advance knowledge about living systems and to turn that knowledge into enhanced health and reduced disability and illness. Thanks to the generosity of Congress and the American people, in the recent fiscal year 2026 appropriations bill, NIH received over $47 billion. A lot of money, but it is worth noting it is only about 1% of the amount our country spends on healthcare in any given year. What is that money used for at NIH? We send over 80% of that money out through grants and contracts to researchers and students at more than 2,500 universities, medical schools, and research institutes across the country. The funds also go out to support hundreds of companies that support their research enterprise as well. In addition to funding investigators and research labs across the country trying to understand Parkinson's research and to develop new and better treatments, we use most of the remaining funds to support research in intramural labs on our campus as well. These intramural investments include award-winning investigators doing fundamental research on Parkinson's and related disorders. And it also includes a clinic focused on Parkinson's and movement disorders where patients can be enrolled in cutting-edge research protocols, among other activities. Next slide, please. NIH is made up of 27 different institutes and centers, a federation of institutes, each of which has their own focus and mission. The structure is designed to ensure focused attention to critical areas and diseases within the context of a broad and collaborative research environment. The National Institute of Neurological Disorders and Stroke, where I serve as acting director, is one of these 27 institutes. And its focus is on discovering how the brain and nervous system work and how to use that knowledge to advance neurological health. There are hundreds of disorders that fall within our mission space, both common and rare, and that includes Parkinson's disease and the related Parkinsonism. Next, can you advance? Thank you. While NINDS is the lead institute for studying these disorders, it is not the only institute supporting research in this space. We collaborate with other institutes, indicated here in teal, who are also supporting other aspects of research into these related diseases. By supporting different angles and approaches to research into Parkinson's disease and related Parkinsonism, we have more shots on goal, if you will, and we hope overall this accelerates progress. Next slide, please. Here you can see the total funding for Parkinson's over the past 15 years or so. Most recently, NIH invested $255 million on Parkinson's disease research. Members of the public and research community can easily look up these research investments on the NIH public website at the project level. And we hope that this transparency also helps to facilitate a greater understanding both among the public, but also facilitate collaborations in the research space. We are in the process of developing new research categories for research reporting to include all the related Parkinsonisms included in the app. Next slide, please. Thanks to the ongoing and generous support from Congress, we at NIH don't just fund a few one-off studies on Parkinson's and related Parkinsonisms. We support the entire biomedical research enterprise that is going to enable discovery of Parkinson's therapy. This schematic on the slide shows how we invest strategically across the entire research pipeline. First and foremost, to overcome a very challenging disease like Parkinson's, we have to support the development of a capable workforce that includes a variety of disciplines and perspectives, from neurologists to geneticists, biochemists, data scientists, and beyond. We have great people working on Parkinson's and related neurodegenerative diseases, and I'm excited to see the research that they move forward. Next, we fund a lot of fundamental discovery work, or simply basic science. There is still so much we don't understand about Parkinson's. We want to know exactly how the disease starts and progresses. What are the non-genetic causes of the disease? Why are some people susceptible and others resilient to disease? We fund translational science, where the fundamental discoveries are further translated from early observations into potential therapeutics or diagnostics.
1 minute remaining.
Thank you. We also fund clinical studies, natural history studies, biomarker development studies, and clinical trials. We also support research resources, programs that enable large-scale collaborative studies and foster multidisciplinary collaboration, as well as provide individual research projects with the opportunity to access biosamples and share expensive technologies to advance discovery and speed the translation of basic scientific discoveries into the clinic. This is the research pipeline we support, but we are not the FDA who you just heard from. So we don't play their regulatory role. When something looks really promising as a therapeutic, it enters the FDA's regulatory domain. Next slide, please. And here are a few examples of projects that research projects that NIH supports across this research pipeline. In the fundamental discovery space, for example, we are looking at how neuronal and non-neuronal cells are damaged and die through disease progression. We're looking at what are the proteins that potentially can foster neurodegeneration through their aggregation, including alpha-synuclein, tau, and other disease-associated proteins. We're looking at things like the gut-brain signaling and dysfunction and its potential role in disease. In the translational science space, some of these projects include the development of biomarkers for Parkinson's and Parkinson's-related dementias, including less invasive skin-based and digital health biomarkers. We are also supporting public-private partnerships like the Accelerating Medicines Partnership for Parkinson's disease and related dementias, which is looking for better ways to differentiate Parkinson's from the related neurodegenerative disorders, such as multiple systems atrophy and progressive supranuclear palsy, among others. In the clinical space, we are looking to identify risk and resilience factors to improve neurosurgical and advanced imaging procedures. And we have a number of studies ongoing looking to establish the safety and efficacy of interventions, including better, more effective use of deep brain stimulation and advanced technology there, cell-based therapies like induced pluripotent stem cells, and as well as trials looking at interventions like exercise to see how that might further potentially modify disease progression. And finally, we support a number of research resources, including biorepositories, as I mentioned earlier, a number of clinical and data platforms, which help to democratize a lot of the information and access to researchers across the country. And finally, I just want to take a moment and note that many of the tools and technologies developed through the Brain Research through Advancing Innovative Neurotechnologies, or BRAIN initiative, have served the Parkinson's community well to accelerate their understanding of the fundamental nature of the disease, and also to enable improvements in devices that serve to intervene in disease progression. So I will stop there, and I look forward to the discussion section. Thank you.
Excellent. Thank you. And next up, we have Dr. Zender from the NSF.
Thanks, Katie. Hi, everyone. I'm going to do the brief overview of the U.S. National Science Foundation. I wonder if we could go to the next slide. All right, so the U.S. National Science Foundation is an independent executive branch agency that was established in the NSF Act of 1950. And we have a very broad mission, which is to promote the progress of science, and through that advance the national health, prosperity, and welfare, and secure the national defense of the nation. So how NSF does that is that we are primarily a funder of research and research infrastructure, where we support the best and the brightest researchers across the U.S. to pursue basic research and to train the future generation of our scientific workforce. So if we can go to the next slide. So unlike some of the other agencies that are represented here, where they have specific programs on applications or diseases, NSF is structured around 7 disciplinary directorates that are meant to cover broad areas of science, ranging from biological sciences, engineering, mathematical and physical sciences, computer and information science and engineering, geoscience and polar programs, STEM education, and social, behavioral, and economic sciences. And across that, there are several cross-disciplinary offices that support integrative activities, international sciences. And then Flo, who would be here today, represents the new Directorate of Technology, Innovation, and Partnerships, which was established in 2022 to help accelerate some of these basic science discoveries that are supported by NSF to future application. In the context of disease, though, again, going back to that idea that we don't have disease-focused programs, and in fact, typically speaking, biological research into the etiology, diagnosis, or treatment of disease is not typically supported. We do support medically motivated research, and that's typically research that's going to advance fundamental understanding in areas of engineering, computer and information science, and mathematical and physical sciences. So if we could go to the next slide. Unsurprisingly, the majority of research in areas of Parkinson's disease and related neurological conditions tends to fall under those directorates, as well through the NSF Directorate of Technology, Innovation, and Partnerships, where we're also supporting small businesses through programs like SBIR as they develop early stage diagnostic technologies. So if we go to the next slide. So some of the themes in terms of research that we support relevant to this advisory committee is research into the fundamental mechanisms of biomolecules, proteins, subcellular biology, all the way up to models of motor control, cognition, and advanced materials and robotics that form the foundation of future technologies. There's a heavy emphasis on imaging and sensing technologies that can allow scientists to better understand the progression of disease and also could lay the foundation for future diagnostic technologies. Interventions and assistive technologies, understanding the physics and the interactions with biology of technologies like wearable robotics, also in the context of deep brain stimulation, theoretical and computational models, and of course, developing out foundations of signal processing and data analytics that can support future models that are deployed to understand the brain. So if we go to the next slide. Just very briefly, again, we're primarily a funder of extramural research. We support researchers at agencies and, or not agencies, excuse me, at institutions across the country. And if you do want to search any of our awards, we do have the link to the public award search there. It's not as good as NIH's search, but it's pretty okay. And I recommend that you take a look. And with that, I think that's all I've got.
Excellent. Thank you so much. We will move on to Dr. Herodopoulos from the Office of the Surgeon General.
Okay. Hello, everyone. Okay, great. You have my slide. Thank you so much. Well, as said earlier, you know, I'm the Principal Deputy Assistant Secretary of Health of the Office of the Assistant Secretary of Health and the National Director of Communications for the Office of the Surgeon General. Just to describe, the Office of the Assistant Secretary of Health has 10 program offices. And so I want you to know the Office of the Surgeon General is just one of them. So we have lots of different things happening here in OASH, but the Surgeon General's role is really the home of the nation's doctors. So it's a role to communicate clearly with public health issues to affect families and communities around the nation. So the Surgeon General oversees the United States Public Health Service Commission Corps. And if you don't know what that is, there actually is a couple of core officers on the call today who are serving on this VACA. But that started 227 years ago in the United States Public Health Service Commission Corps' uniformed service of public health professionals who respond to urgent health needs and serve communities nationwide. So this administration has a major focus on MAHA, or Make America Healthy Again, which is centered on reversing the chronic disease epidemic, and especially in children. So as a key part of the work, it's looking upstream, not only treating disease, but all after it appears, but addressing the root causes of the health. And that includes nutrition and environmental exposures, prevention, healthier communities, and policies that support long-term health across the whole lifespan. And so prevention is focused, the prevention-focused approach is directly relevant to Parkinson's disease, where most cases are not explained by known genetics and where environmental factors play an important role. So I'm so very excited to be on this advisory committee and give you the Office of the Surgeon General's perspective, as the plan aligns closely with several priorities: decreasing cumulative exposure to neurotoxic chemicals, optimizing nutrition. You might have seen our new dietary guidelines come out, and increasing awareness of a lot of the modifiable risk factors. So I'm especially interested in how we can use this coordinated national effort to better understand prevention and reduce avoidable risks and support brain health across the entire lifespan. So I'm not going to describe what Parkinson's is. I think a lot of you understand that if you were on the call today. But this is a powerful example of why a prevention-oriented public health is so important. because today more than 1 million Americans, unfortunately, are living with Parkinson's. And I'm sure every one of you knows somebody who has been diagnosed with it, whether it be a friend or a family member. And nearly 90,000 people are diagnosed annually, and probably a lot that are not diagnosed yet, because we need better biomarkers, which is why we are convening today. And I love hearing from the partners at NIH and NSF and what everyone is doing to try to help get better biomarkers, of course, better treatments, and also access to care as well as services. So the burden is felt not just by patients and families, but across all healthcare sectors and the federal government. And as you can see, the economic cost is quite large at $82.2 billion, at least for what was estimated last year. And we know that the cause is not fully known, but we do know that 13% of people do have a genetic link, but 87 do not, which is where I'm very interested on what could we do to prevent it. So that's where we're assembling. And I wanted to talk about nutrition and the emerging link to the gut biome, which is a special interest of our office. If you go to the next slide. A lot of our initiatives are tied to preventing chronic disease through getting good nutrients, making sure that our gut is healthy. There's been recent interest in gut biome health because it can almost be an access through the vagus nerve to the brain as things are getting introduced into our body through our gut. And so I wanted to describe foods produced on U.S. farms have the potential to be minimally processed, nutrition oriented, and health promoting. But today, there's often problem in our food supply where we have highly processed foods that contain many chemicals and additives that are often packaged and heated in plastic, in films and coatings that may transfer to contaminants in the food. We know far little about the exposures of these contaminants on the brain and brainstem and other organs over a lifetime, the cumulative effects. And I think that hopefully, this convening body can concentrate more on that. And this is especially important for pregnant and breastfeeding women, newborns, infants, and children, and whose brains are still in that rapid developing phase. So early development, the brain is generating cells that may need to survive and function for over 80 years. And that makes early life exposures especially important when we think about long-term risks for neurodegenerative disease like Parkinson's. And we saw with the recent NHANES study data, highly processed food account for about 2/3 of all of our calories consumed by US adults and children. And that means that they're not isolated exposures. These are population-wide exposures happening every day. And early evidence also suggests that food packaging contaminants, including microplastics, can accumulate in human tissues, including the brain. And taken together, these diet-related exposures can amount to a large, almost uncontrollable experiment that we've been exposed to over decades. That's why urgently needed research to determine whether these individual chemicals or cumulative exposure to many chemicals over time may harm the brain and brainstem in ways that can contribute to neurodegeneration and clinical disease. Hence, the nutrition is an important part of our overall strategy. And the brain and brainstem depend on nutrients from food to build, maintain, and regulate the nervous systems across the lifespan. And this includes structural fats and other molecules that support healthy brain function. But nutrition can be viewed in two ways. First, we want diets that support brain development, function, and resilience. And second, we want food and water sources that reduce exposure to contaminants whenever possible. So animal studies suggest that changing in dietary fats can alter the composition of the nervous system, but this remains a little studied in humans, and hopefully in the future we can know more. But for the Office of the Surgeon General, this is an important research priority, better understanding how diet can support the brain, the brainstem, and peripheral nervous systems while also reducing harmful exposures. And the other, I mentioned earlier about the gut biome. If the gut barrier is, I'll say, quote unquote, leaky, we can have increased intestinal permeability, which can be part of a lot of different disease processes. When the gut barrier is weakened, bacterial products and inflammatory signals may move more easily into the body over time. That can contribute to inflammation and affect the gut-brain connection, potentially influencing pathways involved in Parkinson's. A lot of you may know that the genetic risk, GBA1 variants develop Parkinson's, while others do not. And in some studies, healthy GBA1 carriers may show gut microbiome patterns that fall between healthy controls in people with Parkinson's. That suggests that the microbiome may help identify early risk, and it does not yet prove cause and effect. So the main takeaway is that the gut biome may become an important tool for earlier detection and prevention research, but long-term studies, of course, are needed. As always, which is why the NIH has received a lot of good funding. So we are excited that they are going to continue their work. One thing I want to flag for everyone is that fungi, bacteria, and viruses have all been implicated in the latest studies, which is why the general support of natural immunity with a low carbohydrate regular exercise is a promising approach. So of course, we talk about a lot of people, even on the call, who live with Parkinson's, that exercise so much really that has helped their overall disease progression, that really can be linked to lowering glucose levels in the blood, which then can prevent some of harboring infections from infiltrating. So I just want to be broad brush and talking to you about, what do we know, what don't we know? Let's fill the gaps. Let's make big differences with this advisory committee. I know we have 3 more meetings before the end of the year, but these, of course, are not just our initiatives at the Office of Surgeon General with making people healthy, are getting people active, eating well. This is all upstream, not just for Parkinson's disease, but for other ones across the lifespan. And we really want to just show that we can think upstream from many other diseases. So for the opportunity to help connect this with existing prevention infrastructure to the council's work is so exciting. And thank you for having me on today.
Excellent. Thank you so much. So at this point, we're going to transition to the sort of question and not the lunch break, the question and answer portion. So if public members would like to raise their hands, I will call on folks and you can ask questions to your federal colleagues. Yeah, Jesse.
Hi, everyone. Thank you for all of those presentations. That was very helpful. My question is for Captain Abanye. Thank you very much for your update on the CDC surveillance efforts. My question was, is there a pathway to incorporate biomarker-defined prodromal or at-risk populations into future surveillance efforts so that we can really capture the whole timeline and the whole, it's generally believed that, Parkinson's, the biology starts many, many decades before you see outward motor symptoms. So just trying to understand the surveillance efforts and if there's a way to incorporate that. Thank you.
Thank you for the question. So I have one of our subject matter experts here who will answer that question.
Hi, Jesse, just want to clarify that, can you hear me? Yeah, my name is Shauna Mercer, and I'm the lead for the National Neurological Condition Surveillance System. And just want to identify, you submitted some questions, and this was one of them, and we have written answers that will get sent to you, I believe, after this meeting. And 2 things. First, we are following the all of the work on biomarkers very closely. It's really important. And so that's an important part of what we do. Public health surveillance needs to use measures that are widely available, because what we are required to do is to be able to make comparisons for the entire country, to be able to compare between different regions, and to make sure we're being consistent over time. So we need to use things that are widely available from area to area. So at the current time, biomarkers are not consistently reported or used in clinical care. So at this particular moment, we must use the things that are available. And so it doesn't fit for public health surveillance now. However, as I said at the beginning, it's a really exciting area, one that we're watching, and certainly one that we'll continue to support. I hope that reason as to why is clear at the current time, not for lack of interest.
Thank you.
Excellent. Thank you. Dr. Whittingham?
Hi, yes, I'm Sarah Whittingham. This question is for both our Department of War representative and EPA representative. Under the EPA's 2024 Toxic Substance Control Act, most uses of TCE were banned, but the military has been allowed, it was given a 10-year phase-out period for many uses. And so while many Americans are now protected from TCE under this EPA rule, we're still exposing our service members, civilian workers, and military families to this chemical that we know is linked to Parkinson's disease. So given that, what is the Department of War doing to quickly not use TCE? And also, are we doing any surveillance on people that we know have been exposed to these chemicals and may take decades before they present with symptoms of Parkinson's disease?
Hi, Leslie Beltran here. Just want to preface, I'm here representing the Congressionally Directed Medical Research Programs, a research funding organization entity not affiliated kind of directly with military personnel. And so from my vantage point as a program manager of the program, it would be up to the programmatic panel to kind of decide whether or not that makes its way into the program's strategic goals and focus areas and ways that we can address it through our funded research efforts. But again, we're kind of a couple steps back, so it's difficult for me to I certainly would not speak for the military directly, but the ways that we, can gear our research towards our service members is up to the programmatic panel, which is addressed on a yearly basis and will take place early next year.
Thank
you.
Excellent. And then Dr. Beck, I don't know if you wanted to address this as well.
I think the question is really more relevant for DoD, because it was asking about how they're implementing why is my camera not working? Can y'all hear me? There you go. I think the question is more relevant for DoD because it's asking about how they're implementing it. We provided them with a critical use exemption for some very limited necessary critical uses. My understanding is also that the DoD has put in place workplace chemical control protections to ensure that the workers are protected to the extent possible.
Thank you.
Excellent. Thank you. Dr. Standard, and then Debbie, I saw you put a question in the chat, so we'll come to you after that.
Yeah, this is maybe a question for all of us to wrestle with in the coming months, but I think you can hear there's a call here to understand how the epidemiology of Parkinson's is related to environmental and dietary factors here. So trying to put together the data the CDC gathers with the EPA's focus on chemicals and chemical toxicity. I mean, the truth of it is there's no laboratory way of determining whether a chemical might or might not cause Parkinson's with certainty. You won't know for sure until it gets in the environment, and we'll only know that if we're tracking it carefully. So connecting those ideas. And the same could be said of diet, right? Certainly there's room for improvement in diet and may help with many conditions. But if you want to know specifically how that affects Parkinson's, you're really going to need to connect dietary information with epidemiology. And I think this has been a weakness in the field for some years. And maybe as a result of our work here, we can find a way to build some bridges between these. And I don't know if the agencies have any response to that, or if that's just something we have to work on over time.
Just pause here and see if any of our agency partners want to take that question.
This is Amy from NIH. I agree with you about the critical importance of finding a way to capture more consistently environmental exposures and to tie them more directly to clinical outcomes. And I guess it seems to me that there's a number of bottlenecks or barriers to being able to do that. Sensors or ways to capture that information being a critical one, although as we are moving more into wearable digital technologies, maybe those barriers will be lowering. But I would love to hear from you, Dr. Standard, or others on the call, and maybe this is something we can put a pin in and talk more as we move forward and dig into these topics a little bit more. What the barriers are that you see to being able to do that more effectively. And we can maybe think, this could be the kind of thing I think that this committee is well positioned to do, is to think across agencies how we could work together to lower those barriers and facilitate that research happening at a variety of different levels and in a variety of different disciplines.
I see that Dr. Beck, you have your hand up, and then CDC, you unmuted. So we'll go to Dr. Beck and then CDC.
Yeah, I would just add, it's a great question. When we evaluate an existing chemical, we look at all the available data, including the epidemiology studies. As many of you probably know, epidemiology studies are often not perfectly designed and have a lot of problems, especially when they're longitudinal and self-reported. I mean, I remain optimistic. Like Amy mentioned, the wearables, trackable devices, new apps that maybe we could allow us to have more reliable epidemiology studies and better designs. Then the EPA would be thrilled to be able to use that information to inform our chemical risk evaluations. So I think it comes down to what's the study design that we would put in place to make that information usable for a regulatory decision.
CDC.
Thank you. And the one thing that I would just add, because Dr. Stoddard, you started by talking about the connection with surveillance. And I just want to highlight that we have dialogued quite a bit with NIH, NINDS in particular. And so the idea is for there to be connectivity moving forward to think about what we're finding and how that can be used by NIH as they are thinking about research and other things as well. That would obviously extend more broadly to others here. So I think the idea here is connection where appropriate, following on the information that we can provide and how that adds to things that NIH, EPA, and others are thinking about.
Excellent. We will move on to Debbie. I believe you have a question and your hand is up.
Yeah, I was going to actually pose a different question than the one I left in the chat. Just broadly, research is increasingly showing that mixed pathologies exist across neurodegenerative diseases. How is NIH thinking about incorporating this growing understanding into around the complexity of PD and Parkinsonisms as they relate to other areas of neurodegeneration, and thinking about this, since it's spread already just in the Parkinson's umbrella across so many institutes and initiatives? How can we look even more broadly or inclusively to start to think about this in a targeted around shared biology?
Amy?
Yeah, thank you so much. I completely agree with you that this is one of the most significant challenges that we're facing for Parkinson's disease and also for Alzheimer's disease and related dementias. The experience of mixed pathology complicate the person, the patient themselves on their diagnostic odyssey, right? And then in turn, it complicates the researcher's ability to tease apart and deliver treatments. So an enormous area of focus for NIH right now is biomarkers, which is an effort to really develop increasingly more sensitive tools to be able to tease apart the different disease pathologies that are happening in any individual person. And we are working very hard to align those efforts and share those information in shared portals, data portals, to enable greater research across the different disciplines and disease areas. We have to have that information to be able to effectively develop treatments, but we have to, it is a little bit of a chicken and an egg, right? Because we also need to be able to understand more about the individual disease processes to understand if there might be also some sort of effect happening where the different pathologies are intersecting with each other and amplifying the impact. We're also funding research to study various strains of proteins like alpha-synuclein that may affect the different pathologies, and we're making sure that that research then is being shared publicly, broadly, and immediately. But I do want to say that the key of any of this moving forward is really to ensure that we have really productive collaborations going on. That starts at the agency level. It starts within NIH at the institute level, ensuring that our different institutes are working well. And then also that we are encouraging and fostering collaborations at the scientific level, because we need people who are focused on these different pathologies talking to each other and working with each other if we are ever going to be able to deliver greater understanding and care at the level of the individual patient. So I don't have a clear answer for you, but I just want you to know that we absolutely agree that this is an extraordinary challenge, and we remain open to additional suggestions for how we can better coordinate and advance our understanding in these areas of mixed etiology. So thank you for the question.
Thank you. Dr. Oken, I believe your hand has been up.
Yes, thank you. First, let me just say I've been listening along to all these presentations, and this is definitely an inflection point in Parkinson's disease today. I mean, just seeing the coordination of all the different, agencies, both in the government, but outside the government, and also persons with disease and families. And so this is a big moment. I haven't seen this happen before. I think we should just stop and recognize and thank everybody for their contributions. Wanted to make a couple of comments. One is, as we move along on the prevention agenda, I think Dr. Herodopoulos, the EPA, the NIH, I think everybody really touched on it very well, but we should remember that, there's primary, secondary, and tertiary prevention as well. And so we have a huge opportunity. The EPA was talking about looking again at paraquat and getting that information and, other pesticides and chemicals, but we have a huge opportunity if there's any chance for us to show that the science is supportive of getting rid of chemicals and pesticides will reduce the burden on, this generation and the next. I think that's something that we definitely should be doing, but we shouldn't forget that prevention extends to secondary and tertiary. And then the second comment is that we also face a huge challenge in workforce. And we have geriatricians on here. We have general docs on this committee. We've got, patients. We've got, persons with disease and family members. But the burden is getting increasingly larger, and we have to think about how we can scale that burden. And also want to challenge this committee to start thinking about, Parkinson's and neurodegenerations. And there's a whole list of neurodegenerations that have become part of this bill and this act. It turns out that we were late to the game because neurology in particular didn't change its subspecialties until later. And so all of what we fund in the government now are cardiologists and nephrologists and other, parts of medicine. We need to start to think about funding that neurodegenerative disease burden, how they've done it successfully in other diseases, and make sure that that we're bringing in all of the general practitioners, the advanced practice providers. And so super important. But I would love for anybody either at NIH or HHS or EPA just to comment on primary, secondary, and tertiary prevention. But bravo on the discussions and the presentations this morning. Thank you.
And we have 5 minutes remaining.
Thank you. We'll address Dr. Okin's question and then go to Israel. And Dr. Chinpatkin, I see your hand is also up, so we will try to get to you. I don't know if any of the agencies would like to address the question around primary, secondary, tertiary, or I think we're going to have some workforce discussion in the second session.
I don't want to keep talking too much, but let me just say that I completely agree that prevention and risk reduction is a critical area of importance and focused attention. So I'm just going to leave it at that, but I just want to emphasize the critical importance there, and also of workforce development, not just developing a stronger cadre of neurologists who can take up this challenge, but also we have a number of programs specifically focused at bringing neurologists and neurosurgeons into research. And I think that making sure that we have that gap bridged to not just so that the people delivering care and the researchers not just are communicating with each other, but are often the same person.
Thank you. Israel?
What I was doing as I was listening to this, I wrote coordinated effort. And one of the things that we have to be totally and completely honest with ourselves is, for example, gut biome. Is that something that will give us the information that we need to cure this disease, or is it something that just keeps snowballing because everybody's gut biome is different? So we can go down that rabbit hole, or we can say, honestly, that's not something that we need to focus on because we have the biomarkers that are being developed, and that's going to give us the information that we need to get to a cure. So just a comment.
Thank you. And probably something that can be addressed in some of the working groups too as we move forward. Dr. Chinpatkin, I think you have the privilege of being our last question.
Okay, I just had a little bit of a comment and then kind of a question. One is that basically, as I think, Dr. Whittingham makes really clear, Parkinson's, you can have a great, fantastic quality of life with Parkinson's for a very long time, and I think that one aspect I'm thinking about a lot is when that flips a little bit. And in my mind, we can't forget about basically, slowing and, stopping disease after it started, right? But before kind of a lot of the bad parts, for example, like the cognitive impairment, okay? And so I think thinking about this a little bit. And then the other thing I was thinking about when I was listening to, Dr. Baney Adams talk about biomarkers is how we sort of like fit that biomarker piece into making disease modifying trials better, right? So that basically they can be more efficient, they're not, because the trials are how we get to therapies that are going to be approved for people to slow down or treat Parkinson's. So I guess that question is a little bit for FDA.
Dr. Bracchio, I don't know if you want to jump in. Yeah, or if we have any colleagues from NIH, I believe we have Dr. Bonnie Adams, but also Dr. Wright from our Division of Clinical Research is on, if he'd like to take this question.
Sorry, I stepped away for 1 second. Could you repeat the question?
Oh, my question was just about, it's one thing, I've worked on biomarkers for a really long time. I really love them for many, many reasons. But from the perspective of trying to kind of end Parkinson's disease, I do think we have to think about how we make trials efficient, better, kind of better for testing disease modifying therapies in particular. And I think there's probably a role for biomarkers here, but it's going to be complicated to sort of port them from, thinking about phases of disease to actually helping us basically make trials better. And so I just wanted kind of thoughts from, the
Yeah.
FDA end on how we would do that.
Yeah, well, I mean, I think for one thing, it's really important for everyone to understand that there are different types of biomarkers that have different jobs that they're doing, right? And not to think of biomarkers as one thing, like a biomarker, right? There's biomarkers for selecting patients early. There's biomarkers to monitor progression. There's lots of different types. And we need to design studies that are really fixed on identifying those processes, the way those biomarkers particularly work, rather than sort of associational studies. So we have a very rich biomarker program, especially in our division of translational research for validating biomarkers. We also have programs for doing exploratory work in biomarkers, but those are very different things, right? It's one thing to be discovering biomarkers, it's another thing to really be validating them. And it requires different study designs and so on. The other thing is that we really encourage folks in our clinical trial program to include biomarker projects or bring in ancillary studies that can look at biomarkers while the trial is going on, that can really sort of lift all boats later on once the trial is over. And whether those be fluid biomarkers or imaging biomarkers or other types. Of course, there are newer, exciting biomarkers in PD. With seed assays and so on as well. So I hope that's a helpful answer.
Thank you. And I think also another topic perhaps that we can get into is the working groups progress for sure. And with that, I think we will release everyone for lunch. So I don't want to stand between people and food. And we will be back, I believe, at 12:45 to do the second session. So I'll see everyone in 45 minutes.
Yeah, please try to get back by about 12:40 so we can make sure that we start at 12:45, and we will see everyone then.
Produced by the U.S. Department of Health and Human Services.